Greetings from JSS Hospital. We all learn BLS and ACLS because we want to, give precious time to a person as long as possible. We do not want them to die untimely, so they want to have the pleasures of the having born as human beings. So that is the reason we are trying to help them do well and survive from their cardiac arrest. So, see, sudden cardiac arrest is a leading cause of death, and 70% of it happens at home, and 50% is unwitnessed. 10% survive to hospital discharge. You can see most of the victims die without immediate and appropriate intervention. So, timely intervention can save lives. So, our main aim is the basic life support, that is the foundation for saving lives after cardiac arrest, and we have to save our heart and brain as soon as possible within the critical time. So depending upon our proficiency, see, we just have the lay people who can give hands-only CPR, and we have trained people who can be there at the airport and in the swimming pools and the malls, who are capable of giving 30:2 CPR. And this is where we stand, and we have to know both BLS and ACLS. So what is BLS? BLS, it is usually done by the lay people who are minimally trained and without using any specialized equipment. On the other hand, the advanced cardiac life support is given within the hospital by specially trained people, often with advanced equipments and drugs. And IRC has done tremendous work towards modifying the AHA algorithm and guidelines. They have not actually modified it, they have simplified it, tailoring it to the infrastructures of our country and the training of people in our country, and also the stature and the structure of the people in our country. So we have called hands-only CPR as COLS, and we call the basic life support as BCLS, and we have advanced cardiac life support as CCLS. And to our, we have to feel really happy because they have even come out with the suggestions for the CPR, the BLS and ACLS in COVID patients in this pandemic of COVID. So our importance when we are giving basic life support is the compressions and compressions and compressions first, then the airway, and then the breaths. So this can, as I said, can happen anywhere in the airport or railway station or mall or at home, anywhere it can happen. And it is the duty of us to train people to resuscitate, and general public should be aware of it. So to begin with, we have to see if we see any person is unresponsive, look for the scene safety. Then we have to check for the responsiveness, whether he's conscious or not. Immediately, anywhere, whether it's in OR or outside, we can't handle anything alone. So shout for nearby help, activate the emergency response system, and get an AED if possible, and the emergency equipment if it is available close to you. So look for breathing and also check for pulse. If there is normal breathing and pulse, continue to monitor the patient. If there is normal breathing, if there is no breathing and only the pulse is felt, probably the person has respiratory arrest, and give one breath every 6 seconds, and go on giving for 2 minutes. Again, check for pulse because the respiratory arrest can eventually cause the cardiac arrest. Start CPR. If possible, I'll go into this later on. So if there is no breathing and there is only gasping has to be considered as a respiratory arrest, and there is no pulse, what do? Start cardiopulmonary compressions. Perform cycles of 30 compressions and 2 breaths and get the AED as soon as possible. The shocking the patient will improve, if indicated, will improve the return of spontaneous circulation or the survival of the victim. So AED itself will tell us whether, for a lay person who are not trained with this, it will tell us whether it is a shockable rhythm or not a shockable rhythm. If it is shockable, we have to use the AED and give shock as early as possible. If it is not shockable, you have to continue giving compressions until the ALS providers arrive. So I would just show the pictures of these. See, you should not become a victim yourself. So you look for the same safety. So check for the response by tapping the shoulders and call for help. These days, we all have a mobile phone. Activate the emergency response system. Then look for pulse, the carotid pulse, and screen for the breathing. And if the patient is not breathing and there is no pulse, initiate the chest compressions. And you know your heel of the hand has to be kept at the lower part of the chest, and the other hand is put over that, and there is elbow is straight, and the whole pressure is given by the shoulders. You are putting whole of your body weight over the chest. If you have any arthritis or something like that, you could just do with one hand and support the wrist with the other hand. So you have verified the scene safety, you have checked for the responsive and all this. As I already emphasized, if there is only respiratory arrest, you have to give one breath every 6 seconds and help the patient come out of it. So to maintain the airway, we already know as anesthesiologists, so unresponsive patient, unconscious patient, the tongue falls back, the soft tissues fall back. So you have to give the head tilt and the chin lift. And if the patient has cervical injury, consider all trauma patients as having cervical injury. You just give a jaw thrust, or if you have a helping hand, the line mobilization by a person who can help you. So this is the two rescuer scene that I'm showing you. So this person is giving compressions, and the second rescuer has come and he is using the bag mask valve. Usually our PGs have the habit of calling it an ambu bag. Don't call it an ambu bag, it's a bag mask valve, because Ambu is a company who has done it. The Lardal also has done it. So you can efficiently give breaths. So 30:2 a ratio. And if you have two people, one can efficiently hold the mask and another can ventilate with the back. So we have a little bit about the AED. You all know, you all use the defibrillator, but a little bit about the AED quickly. Let me tell you, it might be asked in the examination. It's a lightweight portable computerized device. It delivers shock. It assists the rhythm by itself, more helpful for the lay people, and it's very simple to operate. It prompts all the instructions, and so even the lay person can use it. So you have to just open it, and sometimes it's on, and then it will start giving the prompts. And when it is analyzing the rhythm, nobody is supposed to touch. And whereas it is, if the shock is suggested, then while the AED is charging, you have to give compressions. And once it is charged, again, clear, you don't become the victim yourself again. So you don't touch the patient, all of you, and give the shock and resume CPR again. So the leads can be kept one below the collar. I won't go into the details. Below the right clavicle and another at the anterior axillary. You can see in the pediatric age group, one in front and another can be kept at the back. So there are some special circumstances. If it is a hairy chest, your shock will not work. So you have to shave, or if you have 2 pairs of pads. You can remove the hair with 1 pad, strip it, and put another set of thing. If the person is in a water drowned patient, you will have to wipe the water. And if there are implant defibrillators and pacemakers, they will appear like a lump, and you will have to avoid this. Transdermal medication patches you have to remove, and don't do it on it because the absorption can get fastened and adverse effects can occur. Clothing and jewelry has to be removed. I'll just show you resuscitation, how it can happen for a person, and how a single rescuer and 2 rescuers help. Hope you can hear the audio.
Are you okay? Hello? Are you okay, mister? He's not responding. I need some help. Please come. If possible, somebody come for help. I check for pulse. Simultaneously, I'm assessing breathing. 1,000, 2,000, 3,000, 4,000, 5,000. There is no pulse. There is no obvious breathing. So I need to.
Sorry. Now she has activated the emergency response system and initiated compressions.
9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 27, 28, 29, 30, 31, 32.
This is the sim lab that we have, a beautiful one with all nice mannequins under the able guidance of Gurudat sir. Could have it. Second rescuer arrives. You have to hasten with putting the pads, of course. Put it on. She is only giving compressions, no breaths. She's going to the airway, the first rescue.
Shock advised. Charging. Stay clear of patient. Deliver shock delivered. Hold.
So in between, while charging also, you can give compressions to prevent the interruption. Now, the breaths are given at the rate of 30:2. Yeah, in a pregnant woman, what do we do? So one thing special that is to be done in a pregnant woman is we have to relieve the pressure that can occur on the greater vessels. So you have to put push the uterus towards the left side, not to give a tilt, because that will come in the way of efficient compression. And also along with this, there are a few things that are added in the 2020 guidelines. You don't bother to monitor the fetus as you are giving compressions. Don't worry about that. And there is an emphasis on oxygenation and airway management of the patients. And let me finish here itself. If there is return of spontaneous circulation, you have to give the target temperature management, and during that time you can monitor the fetus. And if there is no return of spontaneous circulation within 5 minutes, take the person for perimortem cesarean section in view of saving both the mother and the fetus. So this is in I won't repeat it as I've already shown it to you. So I've already explained it to you. So it's the same as any other thing except for displacing the uterus, the lateral uterine displacement to relieve the pressure, and the other things continue to be the same. So only the highlights I have given you, the changes. So this is how the displacement is given. So you are giving emphasis to the oxygenation, and you have to just relieve the pressure over the great vessels by lifting. Now, what do you do with the infants and the children? So you call somebody a child between infancy and the puberty. And you all know we call the child being reached puberty when there is the hair in the chest and the axilla, and the breast starts developing in the baby. So it is almost the same, except for the thing that when the breaths, if the baby is not breathing, you have to give one breath every 2 to 3 seconds. That is 20 to 30 breaths have to be given. And if the heart rate is less than 60, consider it as very poor circulation and start CPR. So that is the main difference. Okay, so if it is a witnessed sudden collapse, you can, as I already told you, activate the emergency response and then come back and start compressing. If you have not witnessed the collapse, you give CPR one cycle and then activate the emergency response system, because you do not know when the arrest has happened, and the rest of the things are the same. So in a child, you can see the carotids and the femoral artery, and make sure that the students usually make mistake with this. You check the brachial artery to check for pulse, the brachial artery on the medial aspect of the arm between the shoulder and the elbow. That is very important. And you have two fingers technique at the lower portion of the chest bone that you give compressions, and there is another method wherein you give the thumb encircling technique. These are the two methods of giving cardiac compressions. So let me just show you a video of this, how it is done. This is how you check the response, not show over the shoulders like in adults.
No pulse, no breathing. Activate emergency response system and get an AED. 1, 2, 3, 4, 5.
This is two fingers technique.
8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
See, the second rescuer has come. Now the ratio would be 15:2. 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So the ratio is 15:2.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
All of you might have learned it, but then we are just trying to brush up things for you people. So yet another thing is the opioid poisoning. See, more than 36 million in the US are supposed to be the addicts. So it's always a possibility that they might have consumed opioids. So this you have to doubt if a person has come unresponsive, and the circumstantial evidence is if the bystanders tell you, or if their injection breaks, or if there are the syringes lying by the side, you can suspect it. This would cause either the respiratory arrest and also the pulse, the cardiac arrest. So you might have to give naloxone as early as possible if it is available around, and that would help. So the naloxone intranasally or intramuscular, there are sometimes auto injectors that are available, or intravenous if it is in the hospital. Of course, the lay people, intranasal or intramuscular, intramuscular 0.4 milligrams, and has to be repeated 2 to 3 minutes. A maximum of 10 milligrams can be tried. So the critical concept, what you have to remember is start compressions within 10 seconds after recognizing cardiac arrest. Push hard and push fast. 8 centimeters for adults, not more than that, that will cause chest injury. At least 1/3 the depth of chest, 5 centimeter for children. At least 1/3 the depth of chest, approximately 4 centimeter for infants. Allow complete chest recoil after each compression. You know it is to enhance the venous return to the heart and minimize interruptions in compressions. Again, it has to be less than 10 seconds. In a single rescue, giving 30:2 compression and the breaths. Give effective breaths. See that there is a chest rise and avoid excessive ventilation. Again, the hyperventilation can prevent the venous return and it can decrease the circulation to the cerebrum because it can decrease the cause cerebral vessel vasoconstriction. So it is the thing that you more often see is choking, the foreign body. If it is a mild one, there will be a good air exchange and the patient will cough and will have mild wheeze. Leave him alone, the foreign body, he will throw it out by himself. But this is the universal choking sign when there is complete obstruction in the child and they will not be able to speak, they will not be able to cough, and there is no air exchange. That is when you have to interfere. So it is what is called as the Heimlich's maneuver, which can be tried, and I'll just show you a video of that. See, in a pregnant woman, your hand has to be put a little higher up, and in a baby, you give the back thrust 5 times and turn the baby and give 2 fingers thrust, like how you give the cardiac compressions. So 5 times this and 5 times that, and every 2 minutes you have to check the oral cavity. If it is the foreign body is seen, you will have to remove it. So this is the video showing.
Make a fist with one hand and with the thumb towards the victim's abdomen, encircle the abdomen and locate the navel with one hand, and midway between the navel and the breastbone, give forceful thrust, encircling the other arm around the waist.
And this is how it's done in the baby. And you have to support the chin and the head because they won't have any support in the neck. So this is how it has to be tried. Anytime the child or the adult becomes unconscious, you will have to start with cardiorespiratory CPR. So systematic approach. When you're at outside the hospital, this is the BLS that we are doing, BLS assessment. But once the patient comes to the hospital or in the ambulance, we, along with the BLS assessment and the treat, we will be doing the primary assessment and also the secondary assessment as the ACLS starts. So in the ACLS, the primary assessment will be looking at the airway, breathing, circulation, again, disability, whether the patient is unconscious or exposed completely, and see if there are any other problems that are could be contributing to it. So, and the secondary assessment would be, you have to look at the signs and symptoms, history of allergies, medications, pertinent past history, last intake of food, and the events that might have led to the injury. And most often the cardiac arrest can be because of 5 H's and 5 T's. We know hypovolemia and hypoxia being the most, the common causes. Look into those and treat accordingly. And it can be hydrogen ion excess or the electrolyte imbalance, hypothermia, might have consumed toxins, and tension pneumothorax, tamponade thrombosis. And if the ultrasonography is available and without disturbing the CPR, if you can do the UST, you can immediately detect tension pneumothorax or the pulmonary embolism and hypovolemia in those patients, and immediately treat the cause, and that would facilitate the return of spontaneous circulation. So now, woman in the preoperative holding area. So let me give you the scenarios of bradycardia and tachycardia and how you manage in a group. The team dynamics I'll be telling you all a little later. So now in the pre-op holding area, this can very often happen in our hospital setup. So a woman in the preoperative holding area looks sweaty and pale, complains of chest discomfort and dizziness. The nursing staff in the pre-op holding area will have checked the pulse and the blood pressure and the respiratory rate 18 cycles per minute, and the saturation is 90%, and you go to the area. So what you do is, again, the respiratory, the heart rate is less. Now you are looking at the airway, breathing and circulation. So maintain patent airway, and oxygen is to be given if there is hypoxemia. Cardiac monitor has to be connected, 12 ECG only if it is not taking too much of time. So as Sir has covered most of it, see, if the patient has bradycardia and if it is unstable, when do you call it as unstable? If there is hypotension, if there is altered mental status, there are signs of shock, ischemic chest discomfort and acute heart failure. If none of those are there, you can just monitor the patient. If that is there, the guideline 2020 says that you have to give atropine 1 milligram bolus, which has to be repeated every 4 minutes, and you can try maximum 3 times. If that does not help, most of the times, as was told already, the morbids type 2 and the 3rd degree heart blocks might not respond to our atropine, and some of the patients who are on beta blockers and many of the other conditions might not respond to atropine, and you might have to give transcutaneous pacing. And if that is not available, start them with dopamine infusion, 5 to 20 micrograms. This dosage is changed again in 2020 guidelines, or epinephrine 10 to 20 milligram per minute. So the most common causes why they can be bradycardia is because of the MI, because of drugs and toxics, hypoxia, or the electrolyte imbalance. So if with all these, then if this doesn't help, then call the expert, and transvenous pacing may be needed. Now let me give you a scenario of a tachycardia. A 55-year-old man in the post-operative ward. We encounter this very often. See, following partial gastrectomy, the monitor alarms in the post-op recovery room. There is tachycardia. Patient becomes pale, diaphoretic, and complaining of severe chest discomfort. And the sister says the blood pressure is 10 to 80 by 60, and the heart rate is 170, respiratory rate 28, and rhythm is showing atrial fibrillation. So this is a tachycardia where again the patient is unstable. So you can see this is an unstable because he has there is fall in blood pressure, he is complaining of acute chest discomfort. Yes, he has unstable tachycardia. So the answer is synchronized cardioversion. You know what synchronized difference between the cardioversion and defibrillation. Defibrillation in a fibrillating patient, in an unconscious patient. Cardioversion in the patient who has pulse and who has tachycardia, which is unstable. And in such situations, you have to, if the patient is unstable, if the facilities are available, immediately give synchronized cardioversion. So the patient is conscious, you have to take consent, you have to sedate the patient and explain to the patient and then give synchronized cardioversion. So your shock is synchronizing with QRS. Or if the rhythm is very regular, give adenosine, 6 milligram rapids. Sir already told you about this. The second dose, 12 milligram if required. Now, if the person has tachycardia and is not unstable, if the QRS complex is wide, and if, see, adenosine is always given only if the rhythm is regular and monomorphic, you can consider adenosine or consider the antiarrhythmic drugs like procainamide or amiodarone or sotalol. And if the QRS complex is not wide, say the supraventricular tachycardia and such situations, you can even try the vagal maneuver, but make sure that the patient doesn't have any atherosclerotic blocks in the carotids. Adenosine, if regular, can be tried, then beta blockers and the calcium channel blockers. So this is how you are treating the tachycardia. Now, you are a code team leader. This is very common in your hospitals. Every day there is a code team which has to attend to the arrest anywhere. So respond to a code on, you are responding to a code on general medical floor. The personnel initiated cardiopulmonary resuscitation. The personnel who are there have already started with the basic life support. Victim is unresponsive and monitor shows, I would say, the asystole or ventricular fibrillation. You know, the ventricular fibrillation is like a child scribbling on a paper. That is how you identify the ventricular fibrillation. So the CPR is already started, oxygen is being given, the monitor is connected, and always in the hospital, when you are a trained person who is capable of recognizing the rhythms, and you have to use a manual defibrillator. So the rhythm is shockable. Immediately you have to give shock, defibrillate the patient immediately. That is very, very important for early recovery of spontaneous circulation. So one is given. If the IV line is not started, try to secure an IV line. Immediately give, after 2 minutes, if it's still shockable, give the defibrillation, and ask your team leader, is one of the members, to load epinephrine, and epinephrine has to be repeated every 4 minutes. And consider advanced airway if you are not coming in the way of the resuscitation. So the advanced airway can be your laryngeal mask airway or the tracheal tube or the laryngeal tube. Any of them can be inserted depending upon what is available and your expertise. And after the third shock, you can give amiodarone 300 milligrams or lidocaine and repeat 150 milligrams. And if there are no signs of return of spontaneous circulation, again, you have to continue with the compressions. If the person is as asystole, or there is pulse but it is not able to produce any, there is organized rhythm but it's not able to produce any pulse, then you have to no roll for shock, continue with epinephrine, and you have to continue every 2 minutes, see if it becomes shockable, and then you'll have to repeat the same thing. So the important thing is minimum interruptions with compressions, and also you have to give shock as early as possible. Now, this is about the drugs. I won't go into the details. Magnesium sulfate, if there is a dorsal is D point, this is the D drug. And you know, these days the monitor that is available everywhere is biphasic, so you could give the maximum 200 joules when you give shock to an arrested patient. So what is more important and added in 2020 guidelines is the physiological monitoring during the CPR. So when you intubate or even to the bag mask, you can connect the waveform capnography and make sure that it is always more than 10 mm of mercury. If it is not more than 10 mm of mercury, that means that your CPR is not efficient. And also, if you have the facilities to put an intra-arterial catheter, and if you know the intra-arterial blood pressure, it has to be more than 20 mm of mercury. When there is, and yet another very important thing is chest compression fraction. See, this compression fraction is the amount of time that you are giving compressions to the total resuscitation period, and it has to be more than 80. As I said, there should be minimum interruptions. So when there is return of spontaneous circulation, your ETCO2 would suddenly go up more than 30, and the intra-arterial pressure would go more than 50 to 60 mm of mercury. You would know that you have achieved return of spontaneous circulation. As you can see here in this, the level has gone up. So you have, you can see when there is no compressions, there is no coronary perfusion pressure at all. That is why you have to minimize the interruption, and the fraction should be less than 30. See, in our lab, we have an audio visual feedback device. Just taken, it's not a proper picture. See, as the resuscitation is happening, it is showing you whether it is sufficient or not. It also gives the oxygen saturation. It also gives you the depth at which you are doing. It also gives you the chest compression fraction. So all these will be information will be given by our audio visual feedback. This is yet another thing which is added. And the most important thing these days are the extracorporeal CPR that can be inserted. So before you find the definitive cause and treat, you can put the patient on this, or we have the ventricular assist devices which can also be used to buy time to keep the patient going as you find out the cause for the arrest. So now you have achieved ROSC. Once you achieve the return of spontaneous circulation, that means your resuscitation has succeeded. Again, you look at the airway breathing circulation, maintain SpO2 at 90 to 98%, obtain 12 lead ECG. If there is any sign of myocardial infarction, you will have to take the patient for percutaneous intervention. And if the person does not follow commands, if there are no STT changes, maintain temperature target monitoring. So decrease the temperature to 32 to 36. You know that will protect the vital organs. And you have to continue to get the CT scan and the EEG. You want to find out the reason and how your brain is functioning. So the neuroprognostication usually has to be done after 24. So you are giving the target temperature monitoring for 24 hours, and the neuroprognostication has to start only after the normothermia is achieved. So you are getting series of things to know whether the brain is functioning well. At the end of 72 hours, you do all these, see if there are any hopes of patient recovering. Till then, you can continue with your support to the patient, and then later on you can take a call. So the neuroprognostication is also important. Now the team roles. When you are attending, you are medically an expert, you are able to resuscitate. I'm taking much time. I think maybe within another 10 minutes I'll try to finish. So the team dynamics is very, very important. You will have the code blue, will have already identified team leader. One of them becomes the team leader, and we have other team members. One will take care of the airway, one will take care of the compression, another will take care of the monitor and the defibrillation, one will administer secure and IV lines and the blood for investigations and administer medications, and you have a CPR coach, and also you have a person who records the number of interruptions that are done and when the the adrenaline is to be given, when the shock is to be given. All this is recorded by the timer, and the team leader assigns the jobs, and he makes the treatment decisions, and he gives feedback regarding how the team is working, and he discusses HSNTs and the possibilities with the thing. And in a teamwork, team dynamics, it's very important that the team leader gives clear messages, and the person members close the loop. If the person asks the administrator to load adrenaline, she has to say that she has loaded adrenaline. He asks her to give adrenaline, she has to say that she has given adrenaline, and like that. And even there is a scope for constructive criticism by the team. So that is how the whole team works like an orchestra, and the team leader is the conductor, and that will facilitate the good outcome of the resuscitation. Let me next to show you, it's a little longer video of 8 minutes, but it's very important. In the examination, you might be asked to do any one of those. If you have a lab and if you have to work in a team, just go through it keenly. I have Tachy and Brady scenarios, but I won't be showing Brady scenario, but I just have the Tachy scenario, which you can observe and see how the team works. See, there is a pre-arrest situation, and then the patient arrest, and they achieve return of spontaneous circulation, and how the things happen. So I will just show you this. Nursing staff.
Hello, I'm Dr. Venkatagiri.
Yes, sir.
What's your name?
Ramesh, sir.
What's your age?
45 years.
What's your problem?
I can feel my heartbeat for the last 2 hours. It is causing a lot of disturbance. Yes, yes, sir.
Okay, don't worry, we'll take care of you. We have expert team of doctors here at the ACLS. So, don't mind, I will connect you to the monitor and see if you.
Thank you, sir.
Let us see what's there. Okay, are the monitors connected? Have you secured an IV line?
Overview of the resuscitation. Patient has stable tachy now.
Don't worry, your heart is beating very fast. For that, I will have to give you a few medications. You'll be fine. You'll not feel any pain.
Thank you, sir. Please take care of.
So let me try with the maneuver. I'll just press your neck with both pain and just.
Okay. Okay, sir.
You have got a heavy line in this.
No, almost same, sir. Not much of difference.
Please, Lord Mathew, please load 6 mg of adenosine, and after I tell, please give a 10 ml saline push and lift the left arm. Yeah, thank you now. Sir, are you okay now?
No, sir. Same.
You can repeat 12 mg adenosine this time and give a saline push 10 ml and lift the. How are you?
Sir, doctor, I'm feeling slightly dizzy also.
What's the BP now?
160, sir.
Let us recheck the BP now. How much is the BP now? Oh, it's 70 systolic. Oh,
I'm feeling some chest pain also, sir.
oh, I'm afraid your heart beat is not coming under control. I'll have to do a procedure called cardioversion.
Sir, please do, sir. Please take care, sir.
Very minute electricity to the heart. I'll take consent from Epson while waiting outside. And please give 1 mg midazole so that you should not feel any pain. So you give 1 mg midazole? Yeah. So I will cardioversion. Okay.
has been taken.
Yeah. Everybody clear? Is that it? Coming in 3, 2, 1. Shock delivered. Sir, how are you? Sir? Are you okay? Sir, somebody. There's no pulse, no breathing. Activate code blue. I'm starting to sit there. 1, 2, 3, 4, 5, 6, 8, 9, 10. 1, 2, 3, 10. We're showing it.
Code blue arrived.
Code blue has arrived.
Yeah, please, sorry, Commander, you and Rajeshwar, please take care of this. Commander, please take up the airway. Please take care of the briefing later. Akkama madam, can you please be the CPR coach? Archana madam, please take care of the monitors. So, please, I found that the patient had a unstable.
Just briefing the case to the team.
Charge. Everybody clear? Clear. Shock delivered.
Don't give too much of interruption.
Actually, this patient came with a stable supraarticular tachycardia. I attempted vagal manual because he was stable. After that, I gave adenosine 6 mg followed by 12 mg. After that, we are still having persistent tachycardia. So then he developed hypertension. So I cardioverted the patient to 50 joules. So after that, he developed a VT. So you people have arrived and taken off. Yes. 2 minutes over. So one is still showing VT.
There should not be interruption like this. Sorry for this.
Charge 200 joules. All clear? Everybody clear? Second shock delivered.
Present sickness. Patient, as I was telling. Yeah, please, Madhu, load 1 mg epinephrine and administer. We have given the second shot. So next cycle will have.
After epinephrine, you have to give 20 ml of normal saline bolus and raise the hand for 20 seconds.
Ready. Will not give until I get.
2 minutes over.
Change roles. Switch roles. Will still in Vijish. So please continue to get. You will have like 200 joules and.
Charge 200 joules. Everybody clear?
Everybody clear?
Shock, third shock delivered.
Madhu, please give 300 mg amiodarone and follow it with 10 ml saline push. Have you got the lab reports? No?
There is no pulse.
Is there any disconnect on the plate?
There is no disconnection.
Please, resist the gap. Please give injection epinephrine 1 mg, IV stat, followed by 10 ml saline push. Here, patient has a systole now. Madam, how many minutes have elapsed since we
2 minutes. 2 minutes.
Okay. So please
When
keep
there is-
the epinephrine ready. If it doesn't improve, we'll have to give some more. Okay, so what could be the cause?
Alright, it is not practical.
Yes, it came with unstable tachycardia.
Any other question which
He was telling he had some cardiac disease, but it was not clear.
We set up platform investigations is documented.
2 minutes over.
Set up platform investigation.
Then 2 minutes over.
Switch roles will analyze the rhythm.
So pulse is present, it's stable.
What's the breathing?
BP is around 70, sir.
Is it responding? Sir,
No
are you okay?
response.
Will initiate targeted temperature management. Please give 1 liter of saline fast.
Shall I send you the ACLS, sir?
Yeah, please. Insert an advanced airway, please. And please take a 30 DCD. Let us see what has happened. Now the drops will
Shall I
come.
auscultate you, sir?
Yeah, please.
Yeah, 20 take ECG spectrum.
Just as I expected, there is a acceleration MI. Please inform the cath lab.
Yes, sir.
What's the BP now?
It's still around 90-65.
Mother, please start norepinephrine infusion
Okay, sir.
at 5 micrograms per minute. We have a acceleration MI. Please inform the cath lab.
Inform the
Yeah.
target.
Is it responding? Please ensure target and temperature management. We'll keep the temperature around 34 degrees. Please cold saline. Yeah. Okay. Congrats, member. You are in class.
Thank you, sir.
Thank you.
Let me quickly go through the chain of survival. I think I've already taken too much of time. This is a 2020 thing, and what is added in this is so the in-hospital cardiac arrest, you have to prevent. See, 6 to 8 hours earlier itself, the symptoms and signs of impending arrest might start. So early recognition and prevention is given priority in the in-hospital cardiac arrest. And the other things, activating emergency and high-quality CPR, defibrillation, and the post-cardiac arrest care. And one more important thing that is added is recovery. Once the patient recovers, he might go into post-cardiac arrest syndrome, and he might have cardiac or neurological problems and emotional problems, and so he has to be supported physically and both emotionally. And out of hospital, of course, I already told you the difference between witnessed and the unwitnessed. So call for help, and the other things remain the same. So quickly, the changes that have taken place in 2020, early initiation of CPR by lay riskers. Don't worry too much about the breathing pulse and all unresponsive. Immediately start resuscitation, early administration of epinephrine, real-time audio-visual feedback really helps. Physiological monitoring helps to tell you how efficient your CPR is, and don't give defibrillation one after the other. IV access is more preferred over IVO, and the neuroprognostication is done in the post-cardiac arrest care. And care and support during the recovery has to be given. And during the pregnancy, I already told you the differences. And so the 215, the ventilation is modified to 1 breath every 6 seconds, and the atropine earlier dose was 0.5, that has become 1 milligram. And this, they used to, depending on narrow and wide QRS complex and the irregular rhythm, there were different currents, the strengths that were suggested, but now they say the specific device recommendation has to be followed, and the saturation later on has to be maintained between 92 to 98%, and there are 6 links of both chains of survival, and the IV is preferred over IVO, and the epinephrine given every 4 minutes. And I already told you about the maternal cardiac arrest thing, and the stroke. There are also a few changes, that is endovascular therapy is becoming more popular, and it really helps. So acute coronary syndrome, I won't go into the details of it. You can just follow this in our books also. So you have airway breathing circulation, you are giving aspirin early, and in the ambulance itself, if there are ECG changes, inform the cath lab, and they can be ready for percutaneous intervention. And in the ED or the cath lab, again, you can give aspirin, nitroglycerin, and morphine. And there are, if there is hypotension and inferior wall infarction with hypotension and brady, you don't give nitroglycerin. That is one contraindication. And you don't give nitroglycerin if the patients are on bosphodilasterase. Again, that will cause fall in blood pressure. And it is the same thing if there is ST elevation MI, if it has occurred less than 12 hours period, please take them for balloon inflation. So the door to inflation should be less than 90 minutes. Door to needle, if this is fibrinolysis that you are planning, it should not be more than 30 minutes. If the ECG is normal, you have to monitor them. If there is ST depression, again, you continue to monitor them with the whatever medication that is indicated. So the time is life here. So you have to be very quick in doing things. Coming to the stroke, again, it is the same. So you have to identify that the person has stroke, and you have to give all the other things and refer the patient to the stroke center. And if you have to get the CT as early as possible. And if there is hemorrhage, if there is no hemorrhage, if there is hemorrhage, refer to the neurosurgeon. If there is no hemorrhage, plan for thrombolysis, and also plan for endovascular intervention, either intraarterial thrombolysis, or you can do the stenting, because the facilities are available these days. Again, see, the clock starts as the problem occurs. The patient enters into the ED. Within 10 minutes, you have to assess the patient. Within 25 minutes, the person has to go to CT, or if you have already thought that there is a stroke, you can directly take the patient to CT, and the report has to come within 45 minutes, and within 3 hours, and in special cases within 4.5 hours, you have to consider them for intervention or thrombolysis. As you can see, with the increasing efficiency of resuscitation, the in-hospital recovery has improved. So I've quickly gone through the few more slides. So Abraham Lincoln says, next to creating a life, the finest thing a man can do is save one. Thank you so much for your time.